the outset, let me thank Dr. Mahapatra for bringing us together in this difficult COVID time. Good afternoon, Dr. Sethi. We were together last evening as well in one of the CMEs. So I think it's been, one of the positives of COVID, if we at all look at the positives. So I think my task today has been made quite easy because I have to just enumerate what all is there, device therapy, devices are there for the heart failure management, because the details would be discussed in subsequent talks by my other colleagues, Dr. Ullas and Dr. Keval about LVAD. So, and then they'll be discussing about ICDs and CRTs. So if you look at the heart failure, it has already been being harped on since morning. That's a complex clinical syndrome, and any structural and functional impairment of ventricular filling or the ejection of the blood. So we are predominantly talking about heart failure with reduced ejection fraction, because we don't have to offer much as yet in heart failure with preserved ejection fraction. So the cardinal manifestation of heart failure is obviously the classical signs of, breathlessness and inability to do normal work, swelling all over the body. So we have already discussed this. So the large part of the diagnosis and clinical, assessment is there. And then we need to see whether the patient has gone beyond this stage of devices where, beyond this stage of medication where, they have failed and the patient is still quite symptomatic. And based on this, we always say that there is a class of heart failure with reduced ejection fraction, where the ejection fraction is less than 40%, and then the preserved ejection fraction. And in between, there is a what we call mid-range ejection fraction heart failure patient also. And predominantly, they have also been faring similar to heart failure with reduced ejection fraction. Either the response up to the medications is concerned, or the natural history outcomes are also concerned. So these are different classification. And Dr. Bala has nicely said that we need to subdivide the class 4 into various intermediates so that we can pick and choose who are the patients who would need, heart transplant. So we have already discussed about the pharmacological management. So if we look at the device therapy, this is, ICD is the class 1 recommendation, which is going to be discussed later as well. If the ejection fraction is less than 35% and patient is NYHA class 2 or more, even on the guideline directed medical therapy. And if he's, survival expectancy is more than a year, because this is going to improve his life expectancy. And this is how an ICD would be implanted. And, the patient off and on goes into ventricular tachycardia. The device would sense it and give it a shock and bring it to normal rhythm. And this is a patient where it was an atypical presentation, persistent left superior vena cava, where we have put a device from that into the, so this was slightly difficult implant, but nonetheless, this is the reality which can, sometimes we have to. There are a lot of patients where, the patient would not really need any pacing backup. He is not a candidate for cardiac resynchronization therapy because the narrow QRS, and he just need a defibrillator. And so we have now what we call subcutaneous ICD, where it is, it doesn't touch the heart, everything is outside in the axillary area, and it senses and gives the shock to the patient. It does not do anti-tachy pacing. And this is something which has also been used, but this is more often for patients who have got, channelopathies and all, but definitely every patient who needs an ICD without the need for pacing backup would qualify for this device, though it is, equally effective in all the trials which have been shown, but definitely it's 3 times costlier than the conventional transvenous ICD. So these are few patients who have had this ICD at our center, and we had done it. And if you look at the cardiac resynchronization, that has become a standard of care for patients with heart failure in appropriately indicated subsets. So this is how functionally it would work. So what we do is that we conventionally, in layman terms, we call that it's a 3-wire pacemaker. So conventional, right atrial and right ventricular pacing, and then through the coronary sinus lateral coronary branch, coronary sinus venous branch, we enter into the left posterior lateral area of the left ventricle and implant this lead, and that eventually does a synchrony of electrical activity, and overall, cardiac output improves. So this is how the electrical current will be delivered here, and this increases the synchrony. So this is a cartoon without the CRT, and this is a cartoon which is with CRT. So these are the data which has shown that in appropriately indicated patients, CRT would do a lot of improvement. And with the current subset of medications, like, we had discussion about SGLT2 inhibitors, the ARNI, the MRAs, the beta blockers, the outcomes have really improved. And our heart transplant surgeon, Keval Kishan, Cripps, that probably we are giving him less heart transplant cases. But Dr. Bala has clearly shown that, we need to, get the society more aware about this. And we also see that a lot of patients would have, decrease in mitral regurgitation also with devices, and the outcomes, not only the, quality of life, but also the quantity of life improves. The number of medications also goes down significantly. So these are the few examples where, the patient who had, ejection fraction 20% and had, you can see that the patient had coronaries were fine, and what additional we could do in these. So this is how the guidelines have suggested that we can give these patients defibrillator and CRT. So this is a patient where the QRS is very wide. You can give cardiac resynchronization therapy in these cases, and this is the classical X-ray picture in LAO view, and the RA view looks like, where with this cardiac resynchrony, the narrow QRS becomes, and the cardiac output improves, and also overall mortality and arrhythmic death also comes down. So these are the post-CRT pictures where the QRS has become narrow. These are another patients where 50-year-old normal coronaries again had 25% ejection fraction, and you can see that the QRS is wide, and also AV dissociation. And you can see all the guidelines do suggest that cardiac resynchronization therapy in these appropriately selected patients would be the ideal candidate. And those who already have had these devices like Pacemaker or ICDs, if the QRS has widened over the period of time, we should upgrade them when the battery has finished, and then we can upgrade even in patients who have come with complete heart block and has got wide QRS scale and ejection fraction is lesser than 35%. There also we can give them the cardiac resynchronization therapy, either P or with defibrillator. And again, this is another example where the ejection fraction was 40%, and then the QRS escape, you can see, is wide. There we have given this therapy, and with the help of this and optimal medical therapy, the overall outcome in these group of patients becomes better. But there are certain patients where you may not have really good left, lateral cardiac vein, and you may not have, the good threshold in that area. So in those situations, we can, a new therapy which has come, what we call hot CRT, that can be done. These are patients where the CRT, patient had ICD, ejection fraction further dropped, the heart failure worsened. We upgraded it to what we call CRTD. And this is a case where the patient had, the dual chamber ICD, and there we upgraded it to CRTD again. So a lot of patients who have been implanted these devices, they don't succumb. So initially we used to see that these patients would have loss of life quite early in their course, but with the help of guideline mediated therapy plus these devices, the longevity of these patients are increasing. Even now we have seen that patients who have got atrial fibrillation, initially we never used to give them CRT, but now we have seen that in these patients also, if we can do AV node ablation or control the ventricular rate so much with pharmacotherapy, that we can ensure more than 95% of biventricular pacing where the ejection fraction can improve. So these are the algorithms which clearly shows that if the QRS is wide, we can offer these devices in patients who have got low ejection fraction with atrial fibrillation as well. So, in certain patients, his bundle pacing, briefly I will touch in last few slides, that this has come as a big help in these situations where the QRS is wide, but you are not getting any good target in the, lateral cardiac vein. So in these situations, the hot CRT is again quite helpful, and there the overall benefit to the patient has become much better. And we also say that this is the during implant you look at his bundle potential, and appropriately you can select the site. So this is one of the cases of hot CRT picture. So this is in some patients, Vanita fondly, if you don't have the CRT and the patient can't afford the CRT, then you can put a dual chamber pacemaker with the, his bundle pacing, which can be called poor man's CRT. So I think heart CRT patients would do overall well, and we have seen that, and these are the data from, even one of the paper was written by us, our group also. I think Vanita had taken the lead in that with Dr. Prashant. So now the guidelines have also coming in that direction, that this is something which can be given to our patients who have not a good outcome with conventional CRT, or those where the pacing is needed, the ejection fraction is borderline, and there we can give, and QRS is wide, we can narrow the QRS with his bundle pacing. So to conclusion, heart failure is, a big pandemic, and the devices has come a long way, right from the ICD to CRT and CRTD, and certain other devices like the LVAD and all. I think Dr. Keval will be discussing. So I would stop at this, and if there is any question, I'll be more than happy to answer that. So mechanical circulatory devices and all, I think Dr. Keval is going to discuss, so I'm not going to repeat the thing. So thank you very much for your kind attention. And if there is any question, I'll be more than happy to answer that.